Hello everyone, I am Dr. Velichet Sandeep. This is a brief review of 6th cranial nerve anatomy and radiological approach. So this is basic anatomy I have taken from Edelman MRI 3rd edition. The 6th cranial nerve nuclei lies adjacent to the floor of the 4th ventricle. The 7th nerve takes a turn and courses posteriorly and further goes laterally. The 6th cranial nerve gives the 6th cranial nerve root which goes anteriorly in the pons. At the pons and midbrain junction, it exits anteriorly. This is the intraaxial course of 6th cranial nerve. The blue is the nuclei. This is surrounding the paramedian pontine reticular formation. So this is the brief anatomy of 6th cranial nerve intraaxial course. This is how it exits outside. Coming to the radiology, cranial nerves are best visualized in specialized sequences like T2 drive 3D, which is spin echo, or SSFP, steady state free precision sequences like Fiesta Sys, where you can see the CSF very well with background suppression. I have taken purposefully a multi-system atrophy patient where the brain parenchyma is showing good amount of atrophy and cranial nerves are, especially cistern segments, are well demarcated. This is how the 6th cranial nerve courses internally. So when you see any lesions within the brainstem in 6th cranial nerve palsy, one need to search from this place. This is followed by a cisternal segment. This is how it courses. Further, it goes as a cisternal segment. 6th cranial nerve is a pure motor nerve. This has got long course, that's why it is prone to many pathologies like raised intracranial pressure. This is the cistern segments bilaterally. Though the vessels very commonly about the 6th cranial nerve, it does not cause any neuralgia. It is only 5th, 9th and 7th is spasms. So you don't need to worry about any neurovascular conflict as far as 6th cranial nerve concerned. Then further it pierces the clival dura and there is a small canal called Dorello's canal. It enters there. From there it goes to the petrous apex. From the petrous apex, further it goes to the cavernous sinus. From the cavernous sinus it leaves, exits and enters into the superior orbital fissure. Finally it supplies to the lateral rectus muscle, extraocular muscle. That's the only muscle which is supplied by 6th cranial nerve. That is, the dot is Dorello canal. So let us review how to assess the 6th nerve completely. First of all, the one is the nucleus region. Assess the nucleus whether there is any infiltrative lesion within the brainstem. The second one is cisternal segment. Assess the cisternal segment whether there is any infiltrative lesion in the prepontine cistern. And the third location is near the petrous apex. Assess for any petrous apositis and any bony pathology, any infection over there which is causing compression. This is also an area where it crosses the dura and this is a site where it gets compressed during raised intracranial pressure. After that it enters into the cavernous sinus along with the 3rd, 4th and 5th cranial nerve, but this has got different clinical course. Others traverse through the wall and this goes to the central part of the cavernous sinus. It exits, it reaches to the superior orbital fissure further, so just slightly above the optic foramina. So there we need to search. Again, you might find multiple cranial nerves when pathology involves cavernous sinus or superior orbital fissure syndrome it can present. Further, you need to assess the 6th point. These are the locations you need to assess. 6th is lateral rectus. One need to see whether there is any atrophy of the lateral rectus because of the 6th cranial nerve palsy, or there could be any infiltrative lesion that is called pseudo 6th nerve palsy because of the lateral rectus infiltrative lesion. And this is one important point one need to remember. Once you finish the 6th nerve course and search, don't stop the search there. 6th nerve can be a pseudo localizing sign for raised intracranial pressure. So patients have primary problem is raised ICP, maybe BAH or any other intracranial pressure problem, which can present as a sixth nerve palsy. So look into the orbit. Once from the same cranial nerve protocol, look into the orbits and optic nerve sheath assessment you can do. So from the optic nerve sheath, you can get the information whether there is any signs of rise in intracranial pressure, and end sixth nerve palsy. If you don't find any valid cause elsewhere, always add at the end MR venography, which helps to see whether there is any rise ICP, BAH or IAH is there, which could actually explain the sixth nerve palsy. That's all the anatomy, radiologically and normal anatomy and applied anatomy about sixth nerve review. Thank you. Thank you very much.